Moving on to the next topic, would like to invite the chairpersons. Dr. K.P. Balraj, who is the Professor of Medicine, ESI Hospital, Bengaluru, and Dr. Venkataswamy N., who is the Consultant Physician and Diabetologist at Shreya Hospital, Bengaluru. We welcome you on stage, doctors. Can we have a round of applause?
Good morning, everybody. So we'll move on to the next topic. The role of revolution in cardio-diabetic heart failure, a big step toward improving outcome. So the lecture will be delivered by Dr. Professor P.C. Manoria. He doesn't require any formal introduction. For the formality, he is the Director of Manoria Heart and Critical Care Hospital, Bhopal. He is a former Professor and HOD of Cardiology, GMC, Bhopal. He was the past National President of 9 national associations, including CSI, API, ICC. And he was the past Chairman, Hypertension Council, Asian Pacific Society of Cardiology. And he was the past Vice President, SARC Cardiac Society. He was awarded 7 Lifetime Achievements Award, including Lifetime Achievement Award during the WCCPC 2008 by Bharat Ratna Honorable Sri APJ Abdul Kalam during Indo-US Conclave by Dr. Armstrong, USA. He has got a special award in cardiology by AACIO. Okay, it's over to Dr. P.C. Manoria.
So at the outset, I like to thank Dr. Srinivas for the wonderful hospitality and an excellent conference. Heart failure is a vast topic, and in the restricted time of 20 minutes, I'll highlight some of the key issues. So today I'm going to talk on drug revolution in cardio-diabetic heart failure, a big steps towards improving outcome. All of us know heart failure is a deadly disease, more so in diabetics. Unlike acute myocardial infarction, where you have a quick fix in the form of primary angioplasty, no such quick fix exists for heart failure. What is very distressing is, in the Indian context, 54% of patients of heart failure are diabetic, as you can see on the screen, and the other statistics are displayed on the slide. The most important thing you have to remember is that the human myocyte is not endowed with an endogenous capacity for repair. Once dead is dead forever. And therefore, heart failure, once sets in, runs a malignant progression with a very high morbidity and mortality. The 5-year mortality may be to the tune of 50%, a figure higher than most of the malignant lesions. And in diabetics, it could escalate further to even 85%. Drug therapy or device therapy no doubt blunts this malignant progression but does not arrest it, because the human myocyte is not endowed with an endogenous capacity for repair, and therefore the end result is dismal. And therefore cell therapy emerged as a very exciting option, but after several decades of research, we do not know is the end of the beginning or the beginning of the end. However, the hope remains, and I'm sure one day this would be successful. And therefore, prevention of heart failure has emerged as a very important agenda and is indeed possible. All of us are familiar with this ABCD classification of heart failure. The new thing which we have realized is stage A means you have only risk factors. But now we know that even stage A, you may have an elevation of biomarkers like NT-proBNP. So this is a very interesting observation from the ERIC study. You can see stage A, substantial number of patients had biomarker positive. Once you have a biomarker positive, you are automatically transferred to stage B. And once you have B, We assess by echocardiography and also by marker. So if you have both a biomarker positive, a echocardiographic positive, whether it is incident heart failure reduce, or HFpEF or death, all will be more common if you have both these parameters. So assessing serum biomarkers is now a guideline recommendation even in stage A. In past, we used to keep silence over this. And therefore, the HFA Society of America or the American Society of Preventive Cardiology, the new dicta is heart failure is a preventable condition if you pay proper attention to the risk factors. The other thing is heart failure in diabetes is frequent, forgotten, fatal. The statistics are your own slide. And when we look at the pathophysiology of cardiovascular disease in diabetics, on one hand, we have an atherosclerotic cardiovascular disease, which produces cardiovascular death. On the other hand, we have heart failure. 50% of cardiovascular death is attributed to ASCVD and the remaining 50% to heart failure. Heart failure in diabetes is little different compared to non-diabetic patient. Heart failure predates the development of coronary artery disease. You can see heart failure occurring first and then coronary artery disease. That is very important to remember. Despite control of risk factors in the guideline recommended range, heart failure and hospitalization for heart failure can occur in as much as 45% of the patient, because heart failure in diabetics is also due to diabetic cardiomyopathy and other factors besides ASCVD. The third thing you have to remember is that the earliest defect in diabetic heart failure is diastolic dysfunction and not coronary artery disease. And 1 out of 4 diabetic patients have undiagnosed heart failure, usually HFpEF. Hospitalization for heart failure is more common in diabetics compared to myocardial infarction, and the mortality, of course, is high. The pathogenesis is complex, is displayed on the slide. The third thing you have to remember is heart failure is akin to a malignant disease because mortality is high, just like malignancy. Heart failure runs a malignant progression. Polypharmacy is the rule in both conditions. Both disease has remission and relapses, and remission of heart failure should never be taken as freedom from heart failure. The other dicta you have to remember is that stable heart failure is totally a myth. Heart failure is never stable, even if you are asymptomatic, very little symptom, because apoptosis continues unabated once heart failure sets in, and this you can assess by mild persistent elevation of troponins. And sudden cardiac death is more common in mild heart failure, and these patients, even in stable, may suddenly get hospitalized because without any reason because of continuing apoptosis. Hospitalization of heart failure is a very adverse event in the natural history. Every hospitalization, every rehospitalization takes the patient closer to death. So if somehow you can minimize hospitalization for heart failure, this is indeed a great achievement. And SGLT2 inhibitors play a very important role. They are effective across the board, as you can see. Whatever is the subset, they produce decreased hospitalization for heart failure. The benefit occurs early, as you can see, within days. The other thing you have to remember is door to, just as an acute myocardial infarction, we have door to balloon time or door to device time. You must also follow similar dicta, door to GDMT time. How early you initiate all the 4 drugs, maybe in low doses, and door to maximum dose GDM time. How early you are able to achieve the maximum dose, maximum tolerated dose. Because if you initiate all 4 drugs simultaneously, the benefits are immense, as you can see in the green bar. Why we are talking of this? 1 out of 4 patients hospitalized for heart failure die or is re-hospitalized within 30 days, and the mortality is 10%. If you want to hit at this mortality, quadruple initiation of all the 4 foundational drugs is mandatory, and try to build up the dose. The other thing which is often forgotten is heart failure and CKD should never be treated alone, because there is a close cross-connect between heart failure and CKD. Worsening heart failure worsens CKD, worsening CKD worsens heart failure. And the cardiorenal continuum should be treated as a whole. Don't forget, targeting kidney disease triggers benefits of. And these are the 7 reasons why cardiologists must also focus on kidneys in heart failure. Unfortunately, this is less often practiced. The other thing you have to remember is iron deficiency in heart failure can exist with normal hemoglobins in 2/3 of patients with heart failure. So hemoglobin is not a parameter to assess your iron. For example, this patient, hemoglobin is normal, ferritin is 120. Look at TSAT 11, he has iron deficiency. And the way to diagnose iron deficiency, ferritin should be less than 100, or if ferritin is between 100 to 299, TSAT should be less than 20%. And screening for iron deficiency is a class 1 indication. All patients of persistent heart failure must be evaluated, and symptomatic patient, again, iron therapy is now class 1A therapy. And iron therapy, some people consider the 5th pillar of heart failure because it's very useful, highly underutilized in our country. Vaccination is also mandatory. Influenza vaccine, pneumococcal vaccine, other vaccines, they decrease morbidity and mortality. Adherence, compliance, and treatment inertia, again, one of the major hurdles in the treatment of heart failure. So there's always an ongoing war against heart failure. We have these old drugs we are familiar with, but now we have new additions also, like the SGLT2 inhibitors, vericiguat for worsening heart failure, non-steroidal RNA, semaglutide and tirzepatide are being evaluated for obese phenotype of HFpEF, omecamtiv mecarbil. And we published this in editorial in JAPI, Drug Revolution in Heart Failure, a big step towards improving outcome. Now, what are the achievements of pharmacotherapy in heart failure? This has kicked off a new era of revolution in heart failure, which never existed before. It has created a new subset of heart failure with improved ejection fraction, and ARNI has transformed ICD-eligible patients into ICD-ineligible patients. This is the data of 613 patients, all ejection fraction less than 35%. Within a period of 6 months, you can see the ejection fraction has increased to more than 35% in 37%, and the end of 1 year, roughly 61% of patients, the ejection fraction has increased to more than 35, making them ineligible, and that's why some people call ARNI as a medical ICD. And HFpEF, which was an untreatable condition, no longer remains an orphan disease. Heart failure is a panacea, SGLT2 inhibitors is a panacea for heart failure, a boon for CKD, and what is the beauty of SGLT2? It can be used across the spectrum of heart failure, irrespective of the ejection fraction. Whatever is the ejection fraction, they are beneficial. Unlike other drugs, beta blockers, ARNI, MRAs, they fall short when the ejection fraction increases. And SGLT2 inhibitors have completed the whole cardiovascular continuum and also renal continuum. They have trials in primary prevention, secondary prevention, HFpEF, HFrEF, ADHF, and all the 3 major trials in CKD. These are the 2 landmark trials of HFrEF, both positives. I think all of us are aware of this. Deliver and Emperor trial, Emperor preserved for HFpEF. They also improve the quality of life, the SGLT2 inhibitors, the ARNI. SGLT2 inhibitors has diverse mechanism of action, as you can see on the slide. They also slow down the trajectory of CKD and postpone dialysis by 10 to 15 years. They decrease interstitial edema, which is a unique feature of SGLT2, and they can be used across the cardiorenal continuum, as you can see on this slide, and they can postpone dialysis by 10 to 15 years if you start them early. Vericiguat is a drug for worsening heart failure, 2B indication, and it increases the level of cyclic GMP, which has a favorable effect on the myocardium and the vessels. And it was approved after the Victoria trial, showed a 10% reduction in the primary endpoint of cardiovascular death and hospitalization for heart failure, mainly driven by hospitalization for heart failure. And the NNT you can see is only 24. Omecamtiv mecarbil is still under evaluation. The GALACTIC-HF trial was positive, 8% reduction in the primary endpoint, mainly driven by HF event. CV death was not effective. The other major benefit of the current pharmacotherapy is it is poised to postpone device therapy. We have seen ICD is less often required, CRT is less often, even LVD and cardiac transplantation can be postponed by these therapies. All 4 drugs are class 1 for HFrEF for mildly reduced ejection fraction. Diuretics and SGLT2 are class 1. The other 3 are class 2B. HFpEF prior to 2021 was considered an orphan disease. No treatment was available which could change the outcome of HFpEF. But now we have SGLT2 inhibitors, both DAPA and EMPA, which have shown improved outcome. And SGLT2 is a class 1 recommendation, ARNI 2B, and finerenone is now 2B. Of course, comorbidities are very important in HFpEF, and they are class 1 recommendation, and diuretics, of course, for symptomatic relief is a class 1. Semaglutide and tirzepatide have shown positive results in the trial, but is still not approved by the guidelines. Fine Arts with finerenone is another drug which has shown positive outcome. In mildly reduced ejection fraction HFpEF, you can see a 13% risk reduction in the primary endpoint, worsening HF events or death from cardiovascular disease. Worsening heart failure has decreased. First worsening heart failure or death, again, statistically significant, but death is not effective CV death. Semaglutide and tirzepatide, this is a pooled analysis of STEP HFpEF and STEP HFpEF DM. The trial primary endpoint was only weight reduction and improving the quality of life, but when the pooled analysis was done, you can see a 69% reduction in HF and cardiovascular death, and this was picked up by the Lilly, and they conducted the Summit trial with tirzepatide. The primary endpoint was death from CV cause of worsening heart failure, and the trial was positive. This is pending approval. Which antidiabetics should be used in heart failure? I think you know it much better. SGLT2 is a class 1, metformin 2AC, GLP are neutral, DPP4 are neutral, sitagliptin and linagliptin can be used. Insulin produces fluid retention. 2BC, glitazone should not be used. 3A and DP4, sexagliptin, again, is a class 3 recommendation. Despite major advances, research in heart failure continues unabated. New targets are being attempted, microcirculation, inflammation, cardiomyocytes, and others. So in summary, heart failure, one sets in, runs a malignant progression. All therapies should be escalated to a target dose unless side effects preclude their use, and de-escalation should never be attempted because heart failure is never stable and potentially dangerous. The strategy of oncologists should apply to treatment of heart failure also. The 4 foundational drugs for HFrEF should be utilized for all as they provide incremental benefit and improve survival. The door to maximum GD time should be achieved at the earliest within 1 to 4 weeks. The physician inertia should be minimized. The patient should be motivated for long-term polypharmacy to improve survival, and the 4 foundational drugs are poised to postpone device therapy, even cardiac transplantation. HFpEF no longer remains an orphan disease. Emperor preserve and deliver have shown positive results, and SGLT2 inhibitors are a class 1 indication. In heart failure, the whole cardiorenal continuum should be targeted, and never heart failure or kidney failure alone. Vericiguat is a 2BV recommendation for worsening heart failure. Omecamtiv mecarbil is under evaluation. Iron therapy is very, very important. A normal hemoglobin does not exclude severe iron deficiency. And prevention should be the goal, because heart failure, once sets in, runs some malignant progression. Thank you very much for you.
Sorry, any questions? So, thank you, sir. Thank you for the excellent narration. So, if there are no question, we will move on to the next topic. Thank you.
Thank you, doctors. Thank you to the speaker and the chairpersons. We request you to kindly move to the selfie area, which is outside the hall.